today. This is the ARC of Fort Bend County Parent Education and Support Group, and we are very pleased today to have our speech language pathologist Sabina Duhon joining us today and talking about effective speech practices here. So Sabina, a little bit about her background. She's been in speech pathology for 21 years in the educational setting for 10 of those years, so knowledgeable about children with special needs and speech pathology setting. And Sabina has her master's in speech pathology from the University of North Texas and her certificate of clinical competence from the American Speech Language Hearing Association. And she's, again, worked in the public school for 10 years. She also does some education advocacy and has worked with Disability Rights Texas doing some volunteer work, and also is a graduate of the SEAT training with COPA,
yes,
Council for Parents, Attorneys, and Advocates. So again, she's obviously got a heart for children, and so we're excited to have you here and learn some more from you today, Sabina. Thank you.
Thank you. Okay, so yes, I've been around for a little while, a little bit of what I'm doing now. I spent 10 years working in the school, and based on my experiences in the school, I realized very quickly that I didn't like the way that it was going. I think that there are some really great things that happen in the schools, but there were also some areas that I really felt like were lacking. I tossed around for 3 years going into special education advocacy and did a lot of research about it, and then finally decided, you know what, I'm going to take the plunge. I stopped working at the schools. I went through the SEAT program. I now primarily do pediatric home health. So now I work with kids ages 0 all the way up to 21. I have 4 assistants under me and a couple other speech paths under me, and so we cover all over the Houston area. I do IEEs within different school districts here in the Houston area, and I do advocacy work as well. So I have my hand in a lot of different pots, and I love it. I do have a lot of passion for it. So, speech pathology. So Wikipedia states that speech pathology is a field of expertise practiced by a clinician known as a speech language pathologist, also called a speech and language therapist or speech therapist. We are considered a related health profession along with occupational therapy, physical therapy, and others. SLPs specialize in the evaluation, diagnosis, and treatment of communication disorders, cognitive communication disorders, voice disorders, and swallow disorders. And we play an important role in the diagnosis and treatment of autism spectrum disorder. A few things to know about speech paths, just as far as credentialing is concerned. You are not a speech path if you have not obtained your master's degree in speech pathology, or of course a doctorate in speech pathology. Someone that's completed just a bachelor's level in speech-related fields or communication disorders is considered an assistant. And while they can provide therapy services to your child, they are not educated in the area of assessment. They are not able to remediate plan of cares. And ultimately, it's just their responsibility to carry out the plan of care as written by their supervising speech pathologist, okay? That's always really important to know. Sometimes in schools, especially now, you'll see a lot more assistants actually working with your students in the schools, and even in home health, you'll see a lot of assistants working with your kids. In home health, the thing to know is that a speech pathology assistant is not able to address dysphagia and actually provide feeding therapy to your child. So if you ever have that issue come up, you need to know it has to be a fully licensed speech therapist. So we address all kinds of different things within the school setting, and then of course these also carry over into the home setting. We look at articulation, language, pragmatics, fluency, voice, auditory impairment, and swallow dysfunction. Now, voice, auditory impairment, and swallow function are seen much less in the schools. You primarily see those in homes. Now, if your child has an issue with swallow dysfunction, a lot of school districts do have dysphagia teams now that at least write up a plan that the school can follow and be aware of so that they know that your child has swallowing issues and might require some support. Auditory impairment, a lot of times they serve in more of a consultative manner. It's very, very rare that you'll see any speech pathologist performing things like oral rehab at school. Typically you find that more in the private domain. And then voice, although it can be addressed at the school, oftentimes you'll find that they will argue that that's more of a medical model and therefore not something that needs to be addressed in an educational setting. So in other settings, of course, I've already told you about some of those, and then more specifically the oral rehab for auditory impairment and dysphagia therapy for swallow dysfunction. Cognition is also one that you'll see in the home setting that isn't often addressed in the schools. We can do a lot of work on cognition. Typically you'll see therapists do it more with the geriatric population and adults because it's more of a rehabilitative type of engagement. So they had the skill for whatever reason. They've probably had a neurological insult of some sort, and so they're working to get back the skills that they had. But SpeechPaths can also address it with our younger populations to help with things like short-term and remote memory. So the different diagnoses that we work with. We work with a plethora of diagnoses. I don't think that there's been a diagnosis yet that I haven't seen come across in some way, shape, or form. So we work with patients that have had strokes, brain injuries, something as simple as a developmental delay, and I say that with air quotes, of course, cerebral palsy, Down syndrome, various genetic disorders, hearing loss, cleft palate, even children that have emotional issues. We see a lot of children with autism because, of course, communication is a huge area of concern with a lot of our kids with autism. And I'm seeing more and more kids now, too, with genetic disorders. Seems like the numbers are starting to go up a little bit more, possibly because now our medical field is more equipped to diagnose those things, and so many more people are going through the lengths of having genetic testing done so they can better understand what's happening with their kids. So, age limits for speech therapy. I get asked this question a lot, specifically in the school setting, but ultimately, we're equipped to work with people from birth all the way through the geriatric population. There is no age population that speech pathologists aren't able to work with. And there's not necessarily a point where it should be discontinued or no longer appropriate. If we're seeing progress, whether it be really rapid progress or slow progress, that's okay. Progress is progress, and progress is indicative of an individual's ability to learn and to adapt to the skills that they're being taught. Some of the reasons that we would discontinue treatment would be a lack of functional gain. And functional is sort of the key word there, because some kids and adults are not going to progress as quickly as others, but sometimes even a little bit of progress is a huge step for some of our folks. If I can get someone to activate a switch by pushing down on it, and it takes me a year to get there, but they do it, there's meaning associated with their ability to do that, and that means that I can grow on their communication repertoire. So slow gains are just as good as the fast ones. If there's a significant change in health status, then sometimes we will have to discontinue treatment. Not permanently, but it may be that someone really needs more intervention from physical therapy or occupational therapy so that they're then in a position to be able to have more benefit from speech therapy. It's very hard to do dysphagia therapy with someone that has a lot of issues with positioning and their ability to keep their head up. So it may be that PT and OT need to be involved to work on positioning or to help them build that strength so that safety-wise, they're able to start taking oral nutrition again. And then sometimes there's just a reluctance to participate or a lack of motivation. You know, there's that old saying, you can lead a horse to water, but you can't make it drink. So there are some adults and kids that maybe they've had therapy for a long time, and they're just tired of it. They just want to take a break. You know, it gets exhausting, not only for the parents who are scheduling all of these therapies or the family members scheduling all of it, but for the people doing it. So sometimes you just need to take a break, step back, take a deep breath, and then come back to it. And that's perfectly okay too. In all cases, you have to look at were the expectations appropriate. So before someone is discharged from treatment, was I expecting them to do all of the right things, or were my expectations of them completely unrealistic? If I'm working with someone who has never been able to say a word, and they don't say a word for me in the first 3 months, is that a realistic expectation on my part? Probably not. Probably not. If that's all I'm looking at, then I'm failing that person, because you have to look at everything before you decide that nothing will work, right? The other thing is the effectiveness of the goals. Depending on how the goals are written, am I getting what the goal was intending for me to get from that client? If I've got an assistant working with them and the goal is for the person to be able to communicate yes and no, but I haven't been specific in what that looks like, and so the assistant maybe thought that that needed to be a verbal utterance of yes or no, when all I really cared about was, can they activate a switch with eye gaze? Can they look at a green card or a red card to indicate yes or no? That's very, very different levels of functioning. So looking at the effectiveness of the goals. The service delivery model. Are they getting enough therapy? Are we seeing them 1 time a month, or are we seeing them twice a week? What is the most beneficial for that person? And then, do we have the rapport? Not every therapist works well with every patient that they work with. Sometimes it's just not a fit, and that's okay. You know, we meet people every single day. Some of the people we meet, we think, lifelong friend. Like, I've just met my new best friend, and others we think, oh my gosh, I hope I never see them again. It's the exact same way for the therapist and patient relationship. Sometimes you hit it off right off the bat, and it's a fantastic match, and you have the ability to push them, but keep them with you and keep them engaged and keep them wanting to work. And then sometimes you don't have that relationship, so when you push them for more, they're never going to respond appropriately to you, because there's not a vested interest. They don't want to please you, and you're not motivating to them. And that's okay. That's when you know you've got to just switch therapists. All right. So when therapists are determining eligibility for services, they have to look at several things. And these are really important because these carry over into almost every single setting, whether you're in the school or whether you're in the private domain. You have to look at standard scores on formal assessment data. All of our insurance companies want to see those scores, especially right now in the different Medicaid providers in the state of Texas. That's all they're looking at. They want some standard scores. And if you don't have standard scores to support what you're requesting, chances are you're going to be denied. It's the same thing in public schools. They want you to look at standard scores to determine eligibility. And a lot of times in the schools, speech pathologists will only look at standard scores to determine eligibility, and that's a problem. So, standard scores on formal assessments, and then you need to look at whether the formal assessment provided was appropriate. If I'm looking at a kiddo for language intervention, giving them the Golden Fristo test of articulation probably isn't the most appropriate assessment to give them to figure out if they're going to be eligible for services. You're looking at 2 totally different things. So always make sure that the tests that are being used are appropriate for the areas of concern. And you should know that because anytime that you get a report, there should be a brief description of what the assessment is so that you know. And if it's not there, ask for it. It's always important that you know that the service that your child or family member is getting is appropriate to what it is that the believed weaknesses are. Informal observations. It is very, very, very important that people spend time watching, observing, and taking note of what they see as far as communicative behaviors are concerned. Oftentimes, I can give a vocabulary assessment or one that specifically looks at receptive vocabulary, which is what someone understands, and then expressive vocabulary, which is what they say. They may have a fantastic vocabulary and can't formulate a sentence. So you really want to make sure that you're doing those observations, because that's when you're going to see those things. Or you may have someone that academically does beautifully, but when they stand in front of someone to start talking, they don't have the skills to be able to hold a conversation. Pragmatic deficits. So you always want to do informal observations, and especially in the schools, you want to make sure they've done informal observations. Did they go to the classroom? Did they watch how the child is interacting in there? Did they talk to the teachers about what that looks like? Did they watch the child during structured and unstructured times? Or was it just when the teacher was leading a discussion and the child was just sitting watching? Questionnaires and information obtained should always be from multiple sources. If you're looking at a school-based evaluation, you want to see teacher questionnaires and parent questionnaires. Parents should be a huge part of what an evaluation is built on. Ultimately, you have to look at the big picture. Parents are a part of the ARD committee and the part of the creation of the IEP. The IEP is driven by assessment, so if their input is not in that assessment, then that's a problem. It needs to be added. And then, of course, professional interpretation of the data. If you see score, but there's nothing that explains it all or ties it together or gives you a reason for why, then that's a problem. The reason why the assessment can only be done by a fully licensed speech pathologist is because we have the training to interpret everything that we find. And if there is no interpretation of the results, then anybody could have given that test. Anybody can give a test and give you some scores off of that test, but what does it all mean? So always make sure you know what it all means. And then, of course, throughout the assessment, specifically in the public school setting, everything needs to be structured and unstructured, like I was saying a minute ago. You don't want to just see them when they're, say, participating in science lab. Chances are it's pretty structured. There's a specific assignment they're working on. They've been told what to do. The directions are firm. And while there is engagement, it's typically about what's going on in that lab. During recess, though, that's very unstructured time, or lunch. And that's a great time to observe too, because then you can see what the communication dynamic looks like with their peers. And that's always really important, because at the end of the day, we communicate with our peers on a daily basis, and we need to make sure that that communication is effective.
Can I ask a question for that slide?
Absolutely. We'll go back to that slide then.
Right. It mentioned informal observation.
Mm-hmm.
You know, what is the minimum number of the observation the speech path should be done before?
You know, I would say if a speech pathologist walks into a classroom, stays 15 minutes and leaves, I don't think that's really appropriate. I will tell you that when I do independent evaluations, I stay for an hour to an hour and a half.
Okay.
And that's just in the school. Then I do another observation when I'm in the home.
Okay. So into the house as well?
Yes.
In home at school.
Now that's an IEE, and of course, school speech pathologists don't really have the luxury of being able to go into homes, but they do have the ability to watch the kids in the classroom. And unlike an IEE assessor, they truly have the benefit of being able to pop into that classroom or pop into the lunchroom or go out to recess throughout the day. So even if it's 15 minutes here and there, they truly are able to vary what those observation contexts look like, and they should do that because it gives them so much more information. But a lot of times you'll find that 9 out of 10 of the school FIEs that I look at, there's no observation. There's a teacher questionnaire, and there's no observation.
We have been seeing a lot of questionnaire done by the teacher and the parent as well, but we don't see observations. And one more question about the standard score and the formal assessment data. I have been seeing one evaluation done by one of the school speech pathologists. She clearly stated this evaluation is done with informal measurement procedure. The reason why, because the child does not cooperate, so she cannot finish the
A formal
evaluation
assessment?
right.
Yeah, okay.
In that,
And that's okay.
okay, that's
There
it.
are some kids that cannot complete a standardized measure because there's a very specific protocol that has to be followed to do those. It has to be a quiet room. It has to be one-on-one. They have to be able to follow very specific instructions, sometimes with repetition, sometimes without. So there's a few different tests that we use. One that I use a lot is a functional communication profile. And it is not at all standardized. It's more criterion reference, but you go through and it is a very, very detailed observation of that student. So you still get a lot of information, but it looks more at their functional ability. So I can't take those scores and say, well, he is at the same level as a 6-year, 5-month-old peer. It doesn't give you that kind of information, but it still gives you a lot of information about their communication. So there are some times when a formal cannot be used.
I'm not sure. I'm going to give you one example from that evaluation report.
Okay.
I read that it says the child actually supposed to be tested by reading or orally answer the question.
Okay.
But the speech pathologist provide the child a board and a marker. So actually the child answered the question by writing down, not orally to answer the question. So
Do you know which assessment it was?
it should be, I'm not sure.
There
just
are
speech.
some tests that require a written response. But I will say, if you find that the testing is limiting and doesn't allow the child to demonstrate their true communication skills, then that's a problem. Because the argument could be that while we do look at writing and a child's ability to communicate via the written word, they can't communicate via the written word if they aren't capable of communicating it either orally or via sign or an assistive communication device. It is very difficult to score a child on their writing as well if you know that they have any kind of learning disability, because they can't show success in communication when we already know that they have a problem with writing answers in the first
Right.
place. Does that help at all? So if you feel that a test is limiting in any way, request an additional assessment or request additional information be added to the school's evaluation and tell them, I don't believe that you afforded my child the opportunity to demonstrate what he or she is truly capable of because you asked them to write. And that's already an identified area of weakness. It needs to be more focused on his oral language abilities.
Right. In that case is because the child probably does not have enough ability to orally express his own feeling or his
Okay.
needs. So the school actually denied the service for the child.
Because he could write them?
Yes. But
That's
the
not appropriate.
standard measurement should be orally answer the question, but should provide her something else to. So
What's the child's diagnosis?
I can't tell you. I'm sorry. 'Cause
Okay, that's all right. I will say broadly, I very recently did an IEE on a child with selective mutism who is brilliant, absolutely brilliant, but wasn't verbalizing at school. That is a significant disorder of her speech and language skills, and absolutely a child in that situation qualifies for services.
Good.
Absolutely.
To hear that.
Absolutely.
What
If
area
they're not
would that?
doing it, then they're depriving that child of her, because remember, IDEA says that schools are responsible for preparing our kids even for their future. So after high school, their ability to engage in a job and to live independently and to function appropriately outside of that setting. We have to be able to communicate.
Right. Good.
So depriving the child of services based on the fact that the child can write it is absolutely inappropriate, because that falls under pragmatic language disorder.
Okay. I have to.
That's what I was going to ask. Is which area? So pragmatic.
pragmatic.
So pragmatics.
Pragmatic. Yeah.
Good.
And that is just as important as any other aspect of language. I mean, you and I both know that if you walk into a store and you have to write down for somebody what you want, it breaks down that fluidity of communication, right?
Right.
And especially with a diagnosis like that, with a lot of these kids, it's not that they lack the ability to talk structurally, functionally, anatomically. It is behavioral. But speech plays a large role in that. If you email me, I will send you every piece of literature that I included with that
I will.
IEE.
Thank you.
Okay.
And I'm sorry, I'm not finishing. If,
Okay.
sorry about that. If the report clearly state they did not follow the standard measurement procedure, can we say
Then
that
the
it was
scores are
invalid?
flawed.
It's
The
invalid.
scores are invalid. If
Okay.
they did not follow the standardized, the measures, the way that the protocol is set up for that standardized assessment, then it's not a valid measure.
So they cannot, based on that invalid report, to refuse or deny the service for the
Correct.
child. Good, thank you.
And you might want to, the parent might want to request also an independent evaluation as
Right.
well. Because the other thing the parent can do is they can request the protocols, but the parent can't get the protocols. Only another speech pathologist has the ability to look at and
Right.
interpret protocols. So
Okay.
either way, you would probably want to get a second opinion regardless. An independent evaluation would be kind of the direction that parent would want to go.
Yeah.
They have time.
Yeah.
This is your time.
All right. So, when you get to the point that you're actually getting speech therapy services, goals should be written that are smart. And I'm sure a lot of you have heard this before, and hopefully you've seen it if you do have a child, either in the school-based or even the private setting, because all goals should be written this way. It's not setting specific. They should be specific, they should be measurable, they should be attainable, they should be realistic and results-oriented, and they should be time-based. Good goals will effectively break down the target behavior to ensure that one can demonstrate success within a realistic amount of time. They'll help to identify unforeseen areas of significant weakness. They will also allow for the continuation of services when insurance providers might otherwise deny the authorization. So here's what I mean by that. Here is an example of a long-term school-based goal, okay? By the end of the current IEP year, that's our when, improve speech intelligibility level during interactions with instructional staff and peers. That's why we're writing this goal. Johnny will produce the phoneme S in all word positions when producing single words, phrases, and sentences. That's the what. With 80% accuracy in both structured and unstructured context with minimal cues and or prompts via SLP. Does that sound like a pretty easy goal? It's not. It's a really hard goal. And there's about 10 different components built into that goal. A lot of times I have seen goals that are presented just like this. So let me pose this to you. Let's say that Johnny is able to do that with peers at the end of the IEP year, but not with staff. He didn't meet the goal. Let's say Johnny can do S, but he can only do it in single words. He didn't meet the goal. Let's say Johnny can do it 60% of the time in all of these contexts. He didn't meet the goal. He can only do it structured context. He didn't meet the goal. So there's too many reasons why this goal could potentially fail him. And that's why goals should always be broken down and you should have short-term objectives. This is not necessarily a terrible goal. It's not a goal I would write, but it's not a terrible goal if the short-term objectives support how you expect to get there. And I always encourage short-term objectives because the second that you hit a bump in the road, that speech pathologist should be able to recognize it. Call another ARD meeting and say, hey, we're having a really tough time with this goal. We need to rewrite the goal so it's more attainable. Here's what I'm seeing. Here's how we need to break it down even further because it's not happening the way that it's supposed to. So let's say by the end of the first 9 weeks, Johnny will accurately produce the phoneme S in the following word positions with 80% accuracy. So now we've broken it down. Initial, medial, final. If he doesn't get it in medial, then we know that something's wrong. If he doesn't get it in medial and final, then that speech path can look some more and figure out, okay, how close is he really? We're at the 9 weeks, maybe he's 70% medial, 60% final. Am I gonna stress about that? You know what I mean? Because when you get the progress reports, never accept a W. You know, that whole W, we're working on that goal. You need to have a specific measure of how the student is doing at that exact time, okay? So if you're not getting that kind of information, then you really don't know what's going on. You can have all the well-written objectives in the world, but if you don't know how your child is really progressing through them, then they're not good goals. It's not a good progress update. By the end of the third 9 weeks, Johnny will accurately produce the phony mess when producing 2 to 3 word phrases if 80% of given opportunities when provided with minimal cues and or prompts via the SLP. Again, we get real specific here. What does the phrase look like? How many times do they have to do it? And what kind of cues are we gonna allow to reach that long-term goal? And then the third, of course, by the end of the IEP year, we've moved on to producing sentences. But each step of the way here, we've broken down this long-term goal to make sure that each piece of the puzzle falls into place the way that it's supposed to. And if you don't have goals written this way, you need to find out why. Because this is the best way for you to monitor success and for the therapist to monitor success. Okay. So goals across settings are generally the same, whether you are looking at private therapy goals or school-based goals, clinic goals, hospital goals. They should always be SMART. You should always see the same components. How long are we going to give them? What does the context look like? What is the overall criterion level that we're trying to meet? Is everything broken down so that the second that we believe that we found maybe an area that's more difficult, we can hone in on it? Let's say, for example, that I'm doing this goal and I cannot get my client to lateralize their tongue from right to left. And then I realize that the person actually can't stick out their tongue of their mouth. You know, they can't even point it out straight. Well, they've got to be able to do that before they can stick it out and move it from side to side. So maybe I need to back off of this goal and move back a little bit. And move back to baby steps and instead of trying to take these bigger steps. So another reason why short-term objectives are really important. Oh, I guess that's it. So one thing, there's a couple things I want to point out because I've been seeing it a lot with the IEEs that I do. There is no age that a child should stop receiving speech therapy services in the schools. Just because they move to middle school, that doesn't mean they get dismissed from services, but you will find that they do.
Yes.
Just because they move into high school, that does not mean they should stop getting therapy services, but they do. In fact, what I push for really hard in high school is that communication goals be written in such a way that it helps to set them up for whatever their transitional plan is. Where are they going? What are they doing? Do they know the vocabulary associated with that kind of job? How are they going to communicate with coworkers? All of those things. Is this person going to go to a junior college? Is he capable of having a conversation with a professor? What does that look like? How are we going to enable him to be successful in all of these places? So never, never, never believe that services should somehow be reduced. I had someone tell me one time that by 5th grade, if a child wasn't able to produce all of their sounds, that there was nothing that a speech path could do for them. Wrong. 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 I would hate to think that my child is not capable of learning more than what they know today. That my child isn't capable of progressing after a certain grade level or once they hit a certain age level. I don't know about you guys, but I learn new things every single day. Some things are big, some things are little. Some of them are life lessons, some of them are more academic in nature. I'm still learning. So to say that there is a point where kids stop being able to receive services is absolutely a fallacy. And no one should try to convince you of that. The other thing is this: services should not be based on the amount of time that a therapist is on campus. Services should be based on the need of your child. It's an individualized education plan. It is not a when the therapist is on campus plan. Okay? So don't let that, I can't tell you the number of times I've sat in a meeting and had a therapist say, well, I'm only on campus one time a week. Sorry, I guess you're going to be on campus twice a week now. You know, and the thing is this: a lot of times the therapists are they get to deliver the bad news, and it generally comes from administration. They are extremely stretched thin, and it is very hard for them to cover all of their campuses. That's part of why I left public schools. I felt like I wasn't able to give the service that I wanted to give. So I got out. Not everyone has that luxury. So they do the best that they can. But ultimately, it is the district's responsibility to provide the care that is warranted by the assessment and by the needs of your child. That's why making sure that you have a really good assessment that encompasses all those things we talked about drives the IDP. And when they say, well, it's a language-based classroom, because I hear that a lot. It's a language-based classroom, so they don't need speech services. Who's the language expert on campus?
Speech pathologist.
Not the teacher. The teacher is the educator.
Yeah.
We are the language specialists. Okay.
I've heard that a lot also
Yeah.
with
Right.
goals as well too. I've heard and I've sat and delivered by the speech language pathologist that, oh, you know, we don't write goals unless it has it's got to be tied to one of the academic areas. We will not create a so you hear everything, right? So
Yeah.
one, they would not write, so each one of their speech language goals had an academic component to it, because it's got to be, we've got to have an educational need for it. So so that baffled my mind. That's one aspect of it.
How long have you been hearing that excuse?
That was in one. I've only heard that particular excuse in one particular district.
And let me tell you why I think some of that is coming up.
Yeah.
There's no longer an 8.5% cap on special education.
Yeah.
Speech is a special education service. So there's that. Then you figure all of the Medicaid reform that's hit the state of Texas. There are a lot of kids losing their therapy services outside of school. So a lot of parents are really having to try to push for the school district to make up for the loss that they faced outside of the schools. So now they're trying to make sure that they tie everything to academics rather than looking at the speech and language disorder as a standalone eligibility for a child. A child doesn't have to be failing academically to receive speech services. So it shouldn't have to be tied to an academic goal.
Yeah.
That doesn't drive speech.
Yeah. And then the next steps down from that, because it's always a slide, right? So you wait, the one shoe drops and you wait for what's the next shoe.
Right.
So the next shoe is, oh, well, now that we have, you know, it's been 1 year now where we've had these academic related, you know, the speech goals are all related to the educational need and academics. You know what? The teacher, since these are all academic goals, the teacher is able to carry out these goals. That's why we are justifying a reduction in speech language services. We're going from direct services to consult only and reducing duration and frequency. So that's, again, this is one particular district where I've seen this particular philosophy and structure to the way they're kind of working things. And again, it's basically a denial of,
Right.
it's a way to kind of slide down
And here's what I would
wean
do.
off.
I need to see justification for that.
Yeah.
Where's all of your data?
Yeah.
And data they should be able to hand it to you the second you ask for it.
Wow.
They're supposed to take data as they're doing the services, and if they can't provide you with data upon request, probably isn't any.
I do see data. I do see the class.
That's good.
Really
Here's the
nice
other
and
thing.
pretty.
Here's the other. Is it daily? Is it
It's
regularly
like
taking
it's
data?
Session. Each session they take data.
That's good.
Like
Here's this though that I would ask for then. Anytime they're trying to reduce services, I need you to reassess. You can ask for a reassessment through the school district every single year. You don't have have to wait for the 3 years. You can ask for one every year. If you're trying to reduce services, then I need to see why that's appropriate. And you just telling me that it's appropriate, I don't understand that, because you're supposed to be a language specialist. So I need to see data. I need a new assessment. I need to clearly understand why it is appropriate at this point to reduce services. Because if you're not seeing huge gains,
I don't. Well, that's exactly last time Carrie helped me stop that reduction.
yeah.
But you hear that a lot, and so it's. But there's a lot of value in this, because as a professional, a speech language pathologist, you know what the tests are, what the evaluate. You know, so your perspective on that, you can much more intelligently have a counter response to when they're trying to say things like, again, bring in the academic need, and that the goals are all need to be academic. I mean, so it's almost like you do need to have an expert who can counter that, because mom or advocate or grandma who's there helping you, saying, even though it's true to say, how is, if you're not a speech language pathologist and they have trouble articulating the tongue back and forth, how would you realistically expect a teacher to do that? Of course not. They're not.
Right.
The teacher is not able to give that, and you can't have a goal that's attached to a academic if it's to teach them to
be tied to an academic goal.
Yeah.
Now I will say, because the therapy is taking place in the educational setting, it has to somehow impact the child in the educational setting. But let's say it's articulation, okay? If a child can't have a fluid conversation with his teacher or his peers because he is not readily understood, or because he is so self-conscious of the way that he produces his sounds that he no longer wants to speak out loud in class, that's a big problem. And that does impact him educationally. If a child has a language issue and when they're formulating sentences, they leave all of their articles out, and most of their sentences are only 3 words long. It's more like a phrase. That's a really big problem. And that requires a speech pathologist. Because one thing that you look at too with direct is that child is getting this, typically in the schools, 1 on 5 time, but this person is specifically addressing what that looks like. It is very difficult for a classroom teacher to stop what they're doing to make sure that they are addressing whatever that child's goal is at that moment, especially specific to language, because language is one of those things that as it's happening and you can address it, that's really, really, really great intervention. Being able to work on it right then and there, and teachers don't have that luxury. They just don't. And also, if it's not working out, they haven't had the training to figure out, well, what should I try next, or what can I do that would perhaps bring a different outcome for this child, because they don't have that training.
Right.
They do for education, but they don't for language and communication.
About articulation. I have been hearing so many things about this in different schools in our district. Because we have so many limited English professors, parent here, and a student as well, and they have disability as well. So I have been keep telling, because we speak different language at home, that caused the problem. So it's not because they make it like it sounds like it's not articulation problem. It's because you speak other language. In Chinese, they say, they even showed the research they found to me, say it's in Chinese you specifically you don't have certain sound in English, or maybe you say it in a different way. Like,
how long has your child been exposed to English? How many years?
he was born here,
Okay.
but I speak Chinese most of the time at home, and I have a problem with English, so my pronunciation is not correct. They say because the child was, my son.
So they're saying that your child's articulation problem is because of the model that you're providing.
Right. The child pick up from the parents, not just me, and I have so many.
The child also has the ability to pick up on the models at school
That's right.
and on TV.
Mm-hmm. So
using that as an argument to not address articulation is absolutely inappropriate.
They show me the research.
Just because there are certain sounds that aren't made in your language that are in English, if he can't produce those sounds, that's a problem. And there's a big difference between whether he does it because he's carrying over the specific rules associated with your language to this language. You know what so don't let that be the argument, because the bottom line is he's learning the rules of both languages, and there's no reason why he shouldn't be expected to produce those sounds. And I would even look at it further, and I don't know what the sounds are, okay? So I'm just talking off the cuff here.
They say and the per, an S and L, something like that. The M sign, S, and the L and the P.
Okay.
They show me the research, and actually most of the most child were born in America. The parents try to speak English with them. For my example, I speak English only to my son, even with my broken English, because he is nonverbal. Very limited. So I never speak Chinese to my son, but they still use this as a excuse.
It's not appropriate.
So
Not
you
appropriate.
again, you want to get that an independent. You
Yeah.
always got to counter
Yeah, because the thing is too,
with another
there
professional
is
opinion.
research out there, okay? There is that absolutely support that, and usually it's when the child is a second language learner. But you're saying that your son was born here in the States. He's been exposed to English from day one. There is a second language in the home, but you converse with him strictly in English.
Okay.
Not an appropriate argument. They might have a little bit more of a leg to stand on if he had been speaking another language prior to learning English, but he didn't. And he's exposed to English more during the day than he is to your native language. English is my second language. English was not my first language. I didn't start speaking English until I was 8 years old. I originally spoke Dutch. My mother has a very thick Dutch accent. I don't have a Dutch accent. I learned English. I was able to make all of the sounds the way that they do in English, and I'm still able to make all of the sounds the way that they do in Dutch.
Wow.
And it's very different. So using that argument is not appropriate.
I'm going to ask one last wrap-up question. So one, and then I'll stop the recording. But if you were to give one piece of advice to parents, they come back and they've got maybe a new FIE from the school district that they're looking at, and it has a speech-language pathologist portion of it. What are some of the tips or advice or things that you would tell a parent to look at in that evaluation, or some of the things to consider? What are those things that you wish you could tell every parent about a school speech evaluation, and kind of what to look for? And
Make sure that it's thorough. Very thorough. That there's formal and informal assessment data. And if they're not able to obtain formal, that there's an overabundance of informal data. And some sort of assessment like the functional communication profile. Something that gives them sort of a guideline to help to draw some of the conclusions that they do about your child's speech and language functioning. Make sure there's observations, and a decent amount of observations. 15 minutes doesn't cut it.
Decent amount of, wow, okay.
A decent amount of observations.
It's really, okay.
15 minutes sitting in class while the teacher is lecturing is not a decent observation. They need to actually see when that child is engaged and provide that information. They need to have an active voice in the evaluation. If you are not completing questionnaires and if you are not providing information from home, then they have not taken everything into account. And the ultimate responsibility that they have is that they look at everything. Yes, we relate it back to education in the schools, but they have to look at everything. I would say for sure, oh my gosh, I just totally lost my train of thought. observations, formal and informal assessment data, lots of questionnaires. If your child is in general education and special education, find out from both teachers what they're seeing, not just one. Try to have multiple sources of information. If you don't agree, then say no. I think that's the biggest thing I have to tell parents all the time. You do not have to agree because they told you that they did it and it's right and this is what they believe. You are allowed to disagree. You are allowed to ask for a second opinion. You are allowed to question. If you don't get that assessment a few days before the ARD meeting, that's a problem. You should have ample time to review that assessment and ask questions prior to the ARD meeting. And ultimately, it saves the school time too if you're able to do that. Because then you're able to ask all of the questions before the meeting and hash out what you might have disagreements on. Or for the assessor to get more information prior to the meeting to follow up with you on. I would absolutely say that you need to make sure that they're truly looking at everything and that they're not just considering the student that they see today, but the student that's going to be graduating however many numbers of years from now, and what communication is going to look like for that student then, and what the level of expectation is going to be. Because we're not just thinking about what that child needs this year, we have to think about the future. And when that child gets out of school, how is everything going to look for them? And are we setting them up with language and communication in a way that they're going to be able to be successful? I think that's the biggest thing too.
Well, right. They told me when they try to, because I request one-on-one therapy for my child for the speech, because my son's level is really low. But they keep telling me, well, they use that as a reason why they have to put him in a group to replace the one-on-one. They say in the future you have to expose to others. So
here's how I would argue that. Because there are benefits to group therapy. There really are. As long as he is with peers that are providing appropriate models and pulling the behavior out of him that is ultimately the goal. Okay? If he's sitting with a bunch of other nonverbal kids,
why?
And he's not being provided with all of the models that he needs to help increase his level of success, that's problematic. The other thing is this, he may benefit from the first, let's say 15 minutes of one-on-one, so that the skill is trained and learned, and then using the group setting to demonstrate carryover and to work on his ability to use that skill in a different context that's structured. Okay?
I see.
So sometimes breaking it up with individual and group can be very, very beneficial. Sometimes individual alone is not everything it's cracked up to be, because ultimately you want to see that skill in action.
But in the reality, when I went into the speech session to observe, exactly like what you said, my son was placed with every non-verbal kid with a lot of behavior issue. How can the speech path work with 4 or 5 kids together at the same time? That's like a waste of time.
Right.
That's why I insist one-on-one. So
I would make sure to use that argument then. You know, I believe that he needs one-on-one for the skill to be trained, and then I believe that the second part of that should be that he is involved in a group where that skill is modeled and he can put that skill to use.
how can I determine, define the group, what kind of group he has to be placed in during the group session?
It could be a different set of students that she works with at a different time of the day. It could be that he is pulled into, I don't know anything about your child, but let's say they have a social skills group on campus where it's kids that have a much higher language level, but they're working on socialization skills, and whatever he's working on can pair in there nicely. So he's put with a group that's more verbal and would cause him to use more of his communication skills to be able to interact with other people in that group.
I'm just thinking, how can I need to put something in the comments, say, when it's in a group session, what kind of group it should look like?
You can ask them that.
Okay.
And you can tell them, you know, if your ultimate goal is for him to be able to use these skills,
right,
and that's why he's in a group setting, then he has to be in a group setting where everybody else is either already using this skill or also learning the skill, and there's true reciprocation between them.
Okay.
Because if there's not, and everyone's
Not
not
gonna help.
communicating at that level, then everyone's staying right where they are.
Good.
It has to be functional, and you have to be able to see it get put into play, because that's part of how we learn too. You know, kids learn more from their peers than they typically do from the adults in their lives, because they want to engage with them, they want to talk to them, they want to be involved with them to some level. So it's very motivating for them to be around other peers. That's why they do like pals and buddies and some of those different programs at the schools, because they realize the value of having kids that have special needs with other kids that can serve to be true models for them.
Right.
Thank you
Thank
so
you.
much, Sabina. Thank
Yeah,
you. I'll go
no
ahead and
problem.
end the recording.
Okay.
Thank you.